Good afternoon. Yay. Well, this is exciting. So for those that don't know, this is our third year doing grand rounds here at the School of Public Health at Georgia State. And it's been a joy and an honor to be able to lead our grand rounds committee, in part because we get to bring some really cool people, including one of our alum, back to give some great talks. So I'm just here to welcome you to the School of Public Health for those who are visiting, and just highlight our School of Public Health grand rounds and upcoming lectures. We have actually already filled our fall calendar, which is really exciting. So in September, we will be hosting Dr. Jody Guest, who is a senior vice chair and professor at the Rollins School of Public Health at Emory, so local in Lannon. And then very excited that in November, Dr. Lorraine Dean, who is an associate professor of epidemiology from the Johns Hopkins Bloomberg School of Public Health, will be joining us on November 18th to talk about her work in social epidemiology. But I think more important than that is that I will introduce Dr. Dan Whitaker, who will introduce our speaker. And just thank you all for coming.
Morning, everyone. I'm delighted to welcome Kate back to GSU and to introduce her. So Dr. Kate Guastaferro is an assistant professor in the Department of Social and Behavioral Sciences in the School of Global Public Health at NYU. She holds a secondary appointment in the Silver School of Social Work at NYU. Dr. Guastaferro holds her BA in anthropology from Boston University, her MPH and PhD from Georgia State University's School of Public Health. Woohoo! Kate received the PhD Public Health Achievement Award from Georgia State in 2016. She was also nicknamed at the time by me, Kate the Great. And if I may brag on myself for a minute, that was a spot-on prediction, as you'll hear in a sec. Kate left GSU and went on to complete an NIH-funded T32 postdoc in the Prevention and Methodology Training Program at Penn State. She then became an assistant research professor there, which is what universities do when they want to hang on to their outstanding faculty. And she left a few years later to join the faculty at NYU in the School of Global Public Health on the tenure track. Kate is an intervention scientist by training. Her expertise is in parent-focused, multi-component behavioral interventions to prevent child maltreatment. And she is an expert in the MOST, or multiphase optimization strategy, for intervention development and testing. You can tell how smart she is just by all these big words. She's led 2 statewide prevention trials in Pennsylvania, focusing on the coordinated implementation of evidence-based child sexual abuse prevention programs, including the parent-focused child sexual abuse program that she developed, piloted, and evaluate. Kate has already an impressive academic record with over 60 peer-reviewed publications in really great journals like Prevention Science, Child Maltreatment, and AJPH. She's currently PI on 2 NICHD funded grants, an R21 and an R01, and is the co-I on an R25 training grant to build capacity in the MOST methodology. So let me stop there and just welcome Kate, and she'll talk to you about this.
Didn't know I was gonna cry at the introduction, but thank you, Dan. I'm just love being back here and getting to see so many friends. And what's been really fun is to talk about things I did since I left. So I'm excited to share those things with you, and again, thank you for the invitation to be back and to do that. So I'm focusing on kind of the intersection of intervention science and implementation science, and that's the focus of the talk. Maximizing impact. So really quickly want to kind of set the stage and context for child maltreatment as a public health problem. And just a small moment about my training here at GSU. I don't have to tell many people in the audience that child maltreatment is a public health problem, but basically anywhere else I go, I have to convince them. So I won't convince you, but just want to make sure that we all understand the problem here. When I speak about child maltreatment, I'm talking, it's an umbrella term, and it covers things like physical abuse, sexual abuse, emotional abuse, and neglect. And annually, each year in the US, about 600,000 children are determined to be victims of these different forms of maltreatment. You see the breakdown. of different forms. I won't say more about that. Those who experience child maltreatment are at an increased risk for many of the major causes of morbidity and mortality, including chronic health conditions like obesity, cardiovascular disease, lots of things that we know. They are also at an increased risk for poor mental health throughout the life course, and at an increased risk for substance use. This is just a smattering. There's much more that happens for people who experience this. I, in one study, got to use latent class analysis, told you I was gonna bring it up, with a nationally representative sample of emerging adults. And the first step was to identify different patterns of child maltreatment that were experienced prior to age 18. So I found 3 classes. Nope. So those 3 classes are rare maltreatment, occasional maltreatment with rare sexual abuse, and then frequent maltreatment with some sexual abuse. Those are those 3 columns in the middle of the table. And then what we did is looked at the association of those different patterns of experience with outcomes of substance use and mental health. So what happens to these folks who've experienced child maltreatment prior to age 18 in the emerging adulthood, which is 18 to 25. So in line with many prior studies, the substance use disorder and poor mental health was observed at a higher rate among those who have experience with maltreatment. But what was interesting, and I went too fast, not so expected, was that there's the frequent maltreatment group, there was a higher risk of poor mental health than substance use disorders, and that wasn't so expected. And so what does that mean? It means that maybe the interventions that folks need who've experienced maltreatment are different by the different types of maltreatment that they experience. And so this study, I'm like, okay, emerging adulthood, something's going on here. So then I did a different analysis focusing specifically on substance use disorder, where I'm trying to figure out, are there different ages where this really is a problem, and is that different by different types of child maltreatment? So this analysis uses something called time-varying effect modeling, and we're looking at the age-varying association between the exposure of maltreatment and the past year substance use disorder diagnosis in emerging adulthood. So this is some lines, and this is real science, but I'm interpreting colors of lines for you. So those who reported physical abuse, that's the gray line in this figure, shows that the odds of substance use are highest between 19 and 25. But those who reported, let's say, physical abuse, sexual abuse, sorry, the black line shows that risk is lowest 18 to 21, but then peaks at 23. So that's interesting, that's different. By contrast, those who reported emotional abuse, that's the red line, it's higher at 19, and then it kind of like teeters out. So there's a difference in the odds of experiencing substance use disorder in emerging adulthood based on the different type of maltreatment that you experience. Interactive, right? Oh, cool, okay. So this shows that sexual abuse is a little bit different, has a different pattern than other types of maltreatment. So I focused my career a lot since leaving Georgia State on the prevention of child sexual abuse. And this is a subtype of child maltreatment, so it's under that umbrella. We are talking about any involvement of a kid under the age of 18 in sexual activity that violates social norms, their consent, and law, and they don't understand what's happening to them. So that's really what we're talking about. It is, so about 60,000 kids every year in the US are determined to be victims, but that's only those who are reported and who have enough evidence to be substantiated. So we know that this problem is much, much greater. And the consequences and like the burden of what happens to those victims is estimated to confer about a $9.3 billion annual expense in like the services and stuff that happens after experiencing this. So it's kind of a big deal, right? And sexual abuse is different from other types of child maltreatment. So the etiology is very different. Unlike physical abuse and unlike neglect, this is not a result of a parenting behavioral deficit. Instead, it's kind of about the environment that the kid is in. And it's also unlike other forms of child maltreatment because the biological parent is seldom the perpetrator of child sexual abuse. So that makes intervening with them very different. We'll come back to that thought. But to kind of explore the difference in the consequences of child maltreatment, we used hierarchical regression here to test sexual abuse as a unique predictor of adolescent risky sexual behaviors, specifically pregnancy and motherhood, when in company with other types of maltreatment and these other kind of factors that happen in their life. And what we found, so this was a longitudinal prospective study of maltreated females and matched controls with no experience of maltreatment. And those females were nulliparous, so they hadn't had kids. It's a fancy word. And these females were between the ages of 14 and 19 and followed annually until they were 19. So this is longitudinal. We're seeing what happens to them during adolescence. So what we found, this dark shading, I refer to this paper as the Lego paper because these look like Legos to me. But the darker shading indicates that sexual abuse and physical abuse, it's in step one, it's the bottom line of this figure, are significant predictors of risky sexual behaviors. But sexual abuse remains the only significant predictor of adolescent motherhood and teen pregnancy, considering all of the other things that happen in that life. So sexual abuse is really different. That's the takeaway. All right, so pulling back out, I made the case that sexual abuse is really different. It's a part of child maltreatment. We need to do something to prevent it from happening, right? Preventing child maltreatment has been an active area of research in the literature since the 1960s, but I would argue there is still so much more work to do because there's still 600,000 children every year determined to be victims, right? We do have some universal programs that are delivered to address some of these risk factors, but they don't really work. They don't really have good reach. They don't really have good infrastructure. The majority of resources and evidence have come from these home visiting programs. You may be familiar with one, Safe Care. And so there's lots and lots of federal investment in those home visiting programs. Across the board, tremendous pervasive challenges. And I would argue that these challenges are true outside of just child maltreatment. This is true of any type of prevention program. Engagement is not great, right? We got a high attrition rate when we talk about home visiting programs. We also have a really high turnover rate of those who we train to deliver it. And then add more problems. I'm good at identifying problems. The cost of these programs is really high. And so, of course, we're not preventing child maltreatment. We've got a lot of these barriers and obstacles to come up against. Okay, so when I was here at Georgia State, I had the very good fortune of being trained by the best in prevention, including Mark Chaffin. And this mantra that he said, I attribute to him, but very much he did not originate this, and so I have this very loosely based on some words that he might have said to me one time that he didn't come up with on his own. But the point of it is, an effective intervention doesn't matter unless it reaches the people who need it and who it's designed to affect, you know. And so that has been kind of like this underlying tenet for everything that I've chosen to do since these words. So, impact is what we're talking about here. And there's work in the implementation science literature, specifically work by Russ Glasgow, that identifies or operationalizes impact as the product of effectiveness and reach. Reach means that the greatest proportion of people who are eligible for the program are actually getting it. Makes sense. And effectiveness, well, we have a million ways that we're operationalizing what is effective. And I'm not going to give you all those options, but I think it's really important that intervention scientists be explicit with the way that we're conceptualizing being effective, because if your intervention is designed to be implemented in a population that has any type of health disparity, the way that you define effectiveness could have big implications on health equity, right? And so just because something is good, you gotta make sure it works for everybody, right? And so that's important when we're identifying what is successful, what has impact. So that's like the science version of what I think about with impact. But when I'm talking to my mom about what impact means, these are the questions I think about. Does the program that we're making reach the people, A, who it should be, and B, who we are thinking it's meant to reach? That's an important question. And then 2, is what we're making meeting the needs of the people that we're trying to serve? These seem like really simple questions, right? They're difficult to answer. So, for the rest of the talk, what I'm going to do is showcase my implementation science forward approach to thinking through those questions about impact with 2 specific examples. One is a school-based, child-focused child sexual abuse prevention program, and then the second one is the parent-focused program that I created. So, some context that Dan mentioned in my intro. I was at Penn State previously. They had a large amount of resources available to the prevention and the science related to the prevention of child maltreatment. That came from the Sandusky scandal that emerged in 2012. The NCAA fined Penn State $60 million for what had occurred, and those funds got directed to 2 different pots. $48 million of it went back to the state with the intention of supporting implementation of programs. Remember that. And then $12 million of it went back to Penn State and to fund researchers and science about prevention and treatment for those who've experienced sexual abuse. In 2015, the state, who has this $48 million, so much money to put into prevention, says, okay, Penn State, what program can we implement? So there is no program. There's no pre-packaged, nothing with empirical basis, nothing with any guidance on how to implement, to just plug and play into the situation, right? So that was like the first day of my postdoc, come up with a solution. So this is a little difficult to read, that's fine. We created a multi-level, different kind of player, different focused strategy to prevent child sexual abuse. And the things I'm going to speak about today are in the orange box, so the school-based program and the parent-focused program. That's enough on there. It was supposed to there. Emphasis. Okay, so the school-based program that we selected is called Safe Touches. It is an evidence-based, actually on clearinghouses, evidence-based program delivered in the classroom, and it serves kids K through 3. It's a 50-minute puppet-based workshop. These puppets live in my office, and everyone thinks I'm insane. I love them. So these puppets help kids learn and practice body safety concepts, and use role play scenarios to enact some body safety tools. So you trust your feelings, right? Like I can do the whole workshop for you, but I won't. And the puppets teach these skills to the kids. We teach them to identify their private parts, and that's covered by the bathing suit. Importantly, we don't say the names of the anatomical body parts because schools and policy and parents get very nervous that we might do that, so we don't. They also in the workshop learn the difference between safe and not safe touches, which are confusing, and the kind of underscore repeated thing here is the importance of telling a trusted adult. The very original trial of this study that demonstrated the effectiveness was done in New York City schools, so low income, low resource area, and the greatest gains of this original RCT were observed among 2nd graders compared to 3rd graders. So the 2nd graders had a much higher level of knowledge acquisition. So I pick Safe Touches. Everything is safe, I told you. They all have the same name. Safe Touches, we pick it, we implement it, and in between 2018, 2019 school year, and then 2019 and part of 2020, we launched a longitudinal cohort study. So this is what they look like, the puppets in the classrooms. And we have 4 counties, or 5 counties, 4 sites implementing this program. In total, we deliver Safe Touches to 14,235 second graders. We are in 718 classrooms in 58 school districts, which reflect 92% of all school districts in those 5 counties. Yeah? Thank you. Thank you. I didn't do that. They did that. I just helped. But this longitudinal cohort, we had, of those 14,000 students, 3,600 of them had information in the research and parental permission to participate in research. We had 4 assessment points, pre-workshop, right after the workshop, 6 months later, and then 12 months later. So I'm following these second graders, because that's where we saw the evidence, into 3rd grade and seeing how we can maintain, or if we can maintain that information. So I saw a significant increase in their child sexual abuse related knowledge. There was a small but statistically significant decline between post-workshop and 6 months later. That's very expected in a behavioral intervention. But what was so cool and really great is that there was a significant increase from 6 months to 12 months. Why? I think it's because there's time and there's a lot of more opportunity for them to reflect and reuse some of those skills. That's my suspicion. We don't really know. So what we did in this study, we contributed to the literature that this 50-minute puppet-based workshop gives kids enough knowledge that they can maintain it 12 months later. That's pretty great. We did find some differences related to gender, income of the area, and minority status of the school district. These are hard to read, of course, but what you can take away from these graphs is that there's a significant difference at the beginning, and then it goes away. So regardless of whether the kid identifies as being a boy or a girl, whether it's a high-income, low-income area, whether there's a large proportion of minority students in the district or not, regardless, at the end of this, they have the same level of knowledge, and they've gained about the same amount, and that's huge. So my message is like, all kids need this. So then COVID, right, and I had our implementation got interrupted between 2019 and 2020. We still were in all these counties. They couldn't come back for the follow-up, but I was like, all is not lost. And so we replicated a pre-post test here, pre-workshop, post-workshop, had 2,200 kids complete these surveys, and we saw a significant increase from pre to post, which is what we expect. And the thing that I'm highlighting here is, so the first results that I presented to you is like a mean score, kind of total general outcome. That's my definition of intervention success. And here, I'm looking at an item level, making sure that the way that I'm operationalizing success is that I'm seeing an increase on each one of the items. So just highlighting back to the way that I'm thinking about effectiveness. Okay, then, really cool, we did the first of its kind cost analysis of the Safe Touches program. So this means, what does it take to actually implement the program? It is shocking to me that many people, intervention scientists, don't know how much it costs to implement the program that you create. So we did a ingredients-based approach to a cost analysis. And what these numbers show is that the more kids you have in your school district, the lower the cost of implementing. That makes sense. And the main driver of these costs is facilitator time. So I'm spending a lot of money on providers, and if they don't reach a lot of kids, they're very expensive. They're expensive to begin with, and they should be, but this is a problem. So back to these questions. Does the program reach who it should be and who we intend? I think, yeah, we're doing an okay job of reaching our second graders, but are we meeting all of the needs of those in need? I'm gonna say no, because there's high turnover, the program is really expensive, and so people are not adopting this program. So I took advantage of what I have framed as a natural experience. This, in reality, was a huge violation of implementation fidelity. So this site had turnover, and they lost their staff. The Safe Touches workshop takes 2 facilitators to deliver. Her partner quit, so she delivered it on her own. And she used the videos that we had created during COVID when we weren't in the classrooms, I never said this was okay, never like this was what we should do. She just took it upon herself because she felt strongly kids needed this program. Can you just like pause and imagine what my life was like at that moment as an evaluator? I was like, cool. But I took it as an opportunity, and we did a comparison in these schools of 2 facilitators versus this one rogue facilitator using these videos. And it's still, this is a small pilot, I think in total 1,400 students or whatever I had data for, and it still worked. Kids were still learning something with just that one facilitator. So I thought cost is really high. We can get more sites if we only need one person to deliver it. And so I wrote an R21. And so this is a current project that I have. We call it the Roads to Impact Study. And I let my students name it. I love it. And so here what we're doing is exploring the equivalence. So that's different. In a randomized controlled trial, we're often looking if one does better than the other. This is, are they both the same? Do they both do the same amount of good? Comparing traditional, as usual, safe touches with 2 facilitators, remember very costly, to this modified version where one facilitator is going in and using pre-recorded puppet workshops. And so this is live right now, and I have no data to show you, but this is the plan. Invite me back, I'll tell you how it went. So that was the first part of this talk, focusing on the school-based component and impact, and trying to think of creative ways to bring implementation science and intervention science together. Now, I'm focusing on the parent-focused child sexual abuse program. So, context here. Parents have, you all know, if you know me, I'm prone to hyperbole, but this is true. Parents have been ignored in the prevention of child sexual abuse. And some of that is the reasons I talked about earlier. It's different, right? Like, they are not the ones who are perpetrating, so why would we intervene on parents? Well, because prevention. So parents are uniquely positioned to create environments that protect their kids. They already communicate with their kids regarding health and safety. Let's just enhance that. Parents are the most proximal observers to kid behaviors. And when something changes, they're the ones that are going to notice. They are the ones who can directly facilitate protective environments, right? Create that area. And they are responsible for the supervision of their children. There are some existing programs that were made before I was born, and these programs are not skills-based. They're just teaching people what this phenomenon is. None of them are evidence-based, and none of them have been disseminated widely to achieve any type of impact. So what do we do? There was one paper that I found that said, hey, maybe you should embed a child sexual abuse module into existing parent education programs. Interestingly enough, this is a paper from people in Australia, just to show you that they are very innovative. The parent education programs, which is a different way of saying home visiting programs, such as Safe Care, they are known to modify knowledge, attitudes, and behaviors around these things. Child development, positive parenting interactions, there's evidence that they improve mental health, blah, blah, blah. But none of those programs have demonstrated an impact on rates of child sexual abuse. So our programs that I know and love, we prevent child maltreatment, but they do not have anything specifically about child sexual abuse directly. So that's kind of my entry point, right? And so I decide that I'm going to create an added module. And this was my postdoc. This is what I spent a year making, and I had this 7-point plan of how I would do that. I didn't think that I could do this just with what was in my brain. Got input from experts, including people in this room. Had insight interviews from providers and also parents. And then I pulled every single existing program that I could find that had anything to do with child sexual abuse, and I put it into one document, and it was like 180 pages, which was never going to happen. And so we had a meeting, we distilled it down into essential components that experts were like, yeah, these are really the things. I created a draft curriculum, then I rapid prototyped it, tested it, and did a pilot study. So this is what the content looks like it will look quite familiar if you're familiar with a parenting program, that it includes content related to child development. Home visiting programs spend a lot of time about physical, emotional, social development. Well, this just adds healthy child sexual development. Home visiting programs spend a lot of time about parent-child communication, how to play and talk to your kid. Well, this is age-appropriate child sexual abuse related things. So sex, sexual development, and sexual abuse in an age-appropriate way. And then safety, we spend a lot of time about removing hazards from the home, or car seats, or nutrition. That's all safety. But we don't talk about monitoring your child's activities inside, outside, and online, right? And those are big pressure points. So that's what I did. I enhanced these three essential areas with a specific focus on child sexual abuse. So leveraging what good things happen, adding a little bit more. And so this is what it looks like. Pretty proud of this. We have healthy sexual development, parent-child communication, and child safety. We have, similar to models in this room, a provider guidebook and a parent handbook. So it's manualized, it's structured, it's skills-based, all of these things. So we developed it, we piloted it, everything went really great, people liked it. And then I did a randomized control trial in 2019 in Pennsylvania. So had 110 parents who were enrolled in parents as teachers. And we found, with 110 people, a significant increase in, the top one is knowledge, but basically awareness, of a Cohen's d of 0.16. I put the Cohen's d in for Dan Whitaker, because you would ask me. And then the bottom figure shows the intention to use protective behavior strategies, also a significant effect. Cohen's d of 0.19, small, but we are mighty. And that shows like this is working. That's really promising. But does the program reach who it should be and who we're intending? And are we meeting the needs of those who are in need? I don't really know. 110 people, only in Pennsylvania, an extremely homogeneous sample. And so the other question that is unanswered here, I've said that I have shown an increase in the intention to use behaviors, but I haven't seen that intention to act move into the actual use of protective behaviors. So I need a different study and I need money to do that. Ooh, figure, okay. So I have an R01 that's active in the field right now. It's called the Smart Parents Study. Smart, it's in every title of every program. I would like it to make a mission of those in this audience to stop using the word smart in our names of our programs. So it is a type 2 hybrid effectiveness implementation study. So we're looking both at implementation factors and effectiveness because I already showed that it kind of worked in the original RCT. And what's cool, I think, in a nerd way about this study is that it uses a stepwise cluster randomized trial design, which I learned about in a professional development seminar led by Dan Whitaker. And so this design means every site serves as a control and an experimental. I am currently recruiting parents as teachers affiliate sites. I need 25 to do my study. I have 9. And the thing that is the biggest sell for them is that they get something. So the stepped wedge design, 1, made my study possible, but 2, it means that all the sites get trained in something, and that's a huge buy-in factor for when we're talking about how to take something to scale, how to do these types of rigorous research. So a target sample size of 400 parents who are enrolled in parents as teachers. This is a national trial, and we're recruiting both English and Spanish-speaking families. So we're leveling up, right? But back to those questions. Am I reaching everybody it could be? No. I'm only reaching parents who are enrolled in parents as teachers or another home visiting program, right? So, because I need more to do, I created a universal version of this program. Its name is Smarter Parents, Safer Kids, regrets. But, different colors, it's fine. So I took what I had done in this very selective program that I just talked to you about and adapted it for universal delivery, meaning any parent of a kid under 13 not enrolled in a parenting program, and did a pilot study with some people in this room who were very nice enough to participate, and tested, like, did it need to be very different for universal delivery compared to this selective approach? The answer was no. And I thought that like going into this, the selective approach, remember this is for higher risk parents, we do a lot of formative work about these aspects of communication and parent-child relationship. Well, general parents need that same level of support as well. So that was promising, but not evidence. And so I am in the middle of running a quasi-experimental study of this program. And we are using 9 sites who are funded by the state of Pennsylvania right now to be delivering this program. They are our experimental group. And then I am hustling to find ways to recruit control families in Pennsylvania who would not have access to the program otherwise. This is the best match of a research design to my question. We were talking about this earlier in the student breakfast, that you might have this like beautiful, rigorous, amazing study design in your head, but if it doesn't allow you to answer the research question based on the context and the situation, like then that's not the right pick, right? And so this was the right move, and it is ongoing. I have an amazing RA who has these dashboards that give me numbers on demand. So I presently have, let's see, after survey, well don't look at 2, those numbers are low. But after survey 1, we have 36 people in our experimental and 29 in the control. So we are on our way, slow and steady. So anyway, I'm excited about it. So what happens if a state in particular invests in and prioritizes the impact focus on the prevention of child sexual abuse? I'm going back to this guy, this whole big thing that I told you about at the beginning. This is the investment of state dollars plus Penn State dollars. So between 2018 and 2021, I didn't talk to you about the community-based approach that we had, but that served 14,660 adults. The school-based program I told you was 14,236, and then the parent was 115, but that was because of COVID. That wasn't because of me, okay? So we had big numbers, and to the best of our knowledge, this is the very first coordinated multi-level child sexual abuse prevention strategy. And I presented these data back in 2021 to the committee that funded the work, and they were like, oh, so this works. We got 29 disclosures of child sexual abuse from the school-based workshop that we delivered. That's huge. And in one county, 4 of those allegations went to trial and were convicted, and that doesn't happen. And so like, this works. If we invest money, we know that this is making an impact. So they released another set of funds, and we just completed a 2-year project where the numbers for the Safe Touches program, the puppets, we served 32,000 second graders. Like the state is putting money into this, and they just committed another $3.5 million. So like when a state does that, we see impact, and that's amazing. And I have goosebumps. Okay, so back to this loosely attributed quote. I think it's regardless of what topic we're focused in, an intervention doesn't matter if it's effective, if it's not reaching the people that it needs to reach and meeting their needs. So my ideas here and what I've talked about is not specific or limited to the prevention of child sexual abuse or child maltreatment at all, and can be applied, I think, in any of the areas that people in this room work in. I feel very strongly about this, that we need to consider a different way into thinking about the development of interventions, and it needs to be implementation forward, so that what we are designing meets the context and the people that we need right away. We develop an intervention that costs $1,000 to implement, but the county only has $500 per person, they're not gonna pick it, right? And so that was the focus of my postdoc, where I got training in the intervention optimization approach, and specifically MOST. And I think that those thinking and those questions are really important to advance prevention and intervention science, and that in addition to prioritizing effectiveness, in order to have impact, we also really need to be thinking about efficiency, affordability, scalability, and those other qualities of an intervention. And then in balancing all of those things, you have to consider the ramifications on equity, right? So those are my final thoughts, my things that I think about late at night about how to maximize impact, and I'm done talking. So thank you so much for listening to this. I think I'm meant to have questions. Great. No questions.
Congratulations.
Thank you.
Thank you for your work. What started to swirl in my mind is the issue of equity. You started off by talking about the etiology, of child sexual abuse, and then you talked about kind of access, like who is so. Can you talk a little bit more about what you've learned about that, and also how your interventions and what you're studying is dealing with issues of equity, parents who can't afford childcare?
Yeah. Thank you for that question. So I'm going to answer this in kind of like a different kind of way. And so talking about child sexual abuse is really hard. And parents have a lot of resistance to it. A lot of times there's lived experience that we need to talk through. Providers also have lived experience. And so when I talk about the work and when I train people, I am giving you information to make a decision about. You know the situation best. Here's just some more information to make your decision. And so, like, specifically your question about childcare, one of the things that we talk about monitoring outside the home is dropping in unexpected. Well, I work 3 jobs. How can I possibly do that? And so we acknowledge and respect that situation and come up with different strategies. And so the training of the providers to deliver this is actually really complicated because there's like this foundational protective skill, and then the application of it has to vary to respond to the family's needs. And then to like the bigger question about equity, I am not naive enough to think that my parent-focused approach works for every family. And I expect that in the R01 that we have right now. And so what I did in anticipation of that is, 1, I did make it available in Spanish because that was important to me, but 2, I engaged a partner who is a Center of Excellence related to SOGI, so Sexual Orientation, Gender Identity, and Expression, and they also have like an arm that's cultural sensitivity training. And so I've engaged them in being involved throughout all 5 years of my study, so that when the site or the provider comes to me and they're like, whatever, I don't even know what type of situation might come up, I have a resource to develop a culturally sensitive, culturally tailored response to that situation because I don't know what's going to come up. And I got feedback from a site that I'm trying to recruit right now, and she's like, you're the first person who's ever said that they would change something for our context. And I was like, ooh, but awesome. So that's, I don't know if that answers your question, but that's my answer. Fighting.
Thanks, Kate. Great talk, and we appreciate you sharing with us. Just kind of a big picture question. I know in many of the areas of violence, there is a focus on addressing behaviors of perpetrators, and your approach is very much focused on, potential victims and the context around them. I just wonder if you've thought about what this could look like, or what would a more perpetrator-focused intervention look like, and if that fits within your thinking about this at all.
So never say never is like the one thing that I do believe. But there's such great work and expertise at other institutions that focus on programs for perpetrators or people who have proclivities, I guess maybe is the way I'm going to say that. So specifically at Hopkins, there's such a focus on that work that I didn't want to intermingle it. And I don't think it's a or, I think it's an and. And so I think that it's okay for me to focus on this very primary prevention focus, while that team maybe focuses on developing something for a different kind of entry point. So yes, and maybe.
Hey, again.
Hey.
Good to see you again.
Thanks.
My question, I love seeing the data that you have already and getting to see all that and some of the results and kids served and families served. I was just curious if you have any stories of, specifically for the Safe Touches program, from kids' reactions. Like, what is their reaction to this? And kind of
Okay, so Roddy is
share.
like not a plant, but this question will make me cry, so we're gonna try to like pull it back. So first of all, like the puppets I joke about, and they're kind of silly looking, right? But the way that these kids watch Herbert and Eunice and Petunia and Toby teach them these skills, it's incredible. And I've gotten the opportunity to see it in younger classrooms where kids are like all squirrely and like want to be outside playing, and the minutes the puppet starts teaching them these skills, they're like, oh. And so in that workshop, lots of interaction, lots of questions, and so kids will raise their hand and be like, so is this a not safe touch? And we've had lots. Like, so the last study, we had 350 concerning statements come up in one academic year. Not all of those were disclosures of child sexual abuse, but a kid saying something enough to have an adult pay attention. We'll see. Like, that's so important to me. And one just story I will tell you in particular, so this is not direct from the mouth of the child, but she, after the workshop, this child disclosed to her mom that she had been being sexually abused. And during the forensic interview, I'm not entirely sure of how this worked, but the mom said something to the kid that was like, how come you haven't said anything before? I'm not crying. And she was like, I didn't have the words until the puppet told me, right? I can't. Like, those things make me just very misty, dusty in here. But that, like, that's the reaction, and that's why we'll keep doing this no matter what.
Hi.
Hi.
I was just wondering if this is being implemented in states further south. And I was also thinking about age of consent as well, and what those laws might imply.
Yeah. So I think, thank you. The beautiful situation in Pennsylvania that there is this tremendous amount of resources available for prevention in particular created this really great opportunity. To the best of my knowledge, there aren't as many resources in other states, but what my plan is and hope for is to be able to take this approach, make it as efficient and affordable as we can, and apply it in other states who maybe don't have $60 million, but here is a really efficient way and a package that you can just take, right, and implement. And so, no, but anyone's watching.
Hi, thanks so
Hi.
much for your great presentation.
Thanks.
I'm curious in your work with schools, so we know that children who have disabilities, and specifically kids with intellectual and developmental disabilities, have unique and heightened risk for experiencing sexual abuse. In your work with schools, what have the conversations been about how students with disabilities are included in these interventions? How have parents perceived? I'm just curious about like how that's been addressed.
So great question. Lots of answers. So first thing is that this is tested in classrooms that are not specifically kids that have intellectual and developmental disabilities currently. But if the classroom and that organization is set up in a way that there are students in that classroom, we deliver it. And I've seen it happen where there are those aides helping to explain concepts and things like that. And they still get it, like they get the same information, and it's super important. So I've actually been partnering with the agency who developed it to think about a ASD version of this program. And they did a pilot, and it was amazing. And my question is, shouldn't that version be for all kids? And so maybe we should talk, Erin. And I think that's the next kind of thinking and thought about this. Parents of kids that have IDD call, and they have lots of questions about the way that things are presented. And I do the same thing back to them. I'm like, you know your kid best, and if this is not going to work for them, like maybe they're going to be in the other room. But here's how this goes. Here's we use puppets. And I've not had a parent not keep their kid in the classroom when they call me and ask me. There's plenty of parents who are like, nope, Can't teach my kid anything.
Hi.
Hi.
I think this is really interesting and groundbreaking research and work that
Ooh.
you've been able to do.
Thank you.
I wanted to ask, have you ever thought about maybe using what the intervention could look like if you were targeting older children who never got the space or opportunity to have that type of education and ability to like you said, like learn like what that is.
Yeah. So you're talking specifically about the child-focused component?
Yes.
Yeah. So I don't want to lay like all my cards on the table, but yes, there is no evidence-based program that serves kids specifically focused on the prevention of child sexual abuse. That is evidence-based, that serves kids beyond grade 3. So big need. More programs exist, and some are evidence-based and some are really great, but they're not just sexual abuse. They've got bullying, cyberbullying, other very important things, but I think there's a lot of impact. This is one session, and these gains are maintained for a year, and I think that there could be a logical plan to make a every year program. There's legislation in place to support that, and I'm not going to say more because I want to do this.
Got you.
But
Nice.
you're getting your steps in.
Thank you. I'm Lucy Popova. We
Hi.
haven't met, but my question is, do you think in terms of going beyond schools and just really mass producing and like doing like YouTube videos or TikTok
Yeah.
and stuff like that, and what are the challenges with that? Because it seems like being the delivery and parental agreement, it seems to be like a big issue.
Yeah, big issue. I think it's a great question. The sites that I've been lucky enough to work with in Pennsylvania have raised this, and they're like, what if we just made TikTok videos and parents watched it? And I was like, well, if you want to be a TikTok star, go for it. But I think I have questions and challenges about it, and I think a strategy that I feel comfortable with is using those social media and like more, mass reaching things to be the like hook, the thing that gets parents engaged, and then I can control a little. I'm a control freak, but I could control a little bit more of that implementation and the fidelity of the program, and people getting all of the things that I think that they need in order to change their behavior. If I could use TikTok to get them to sign up for the program or something like that. I'm not saying no, but that's where I stand. I think at least today.
I wanted to follow up on that thought, though. Given that it is a public health issue, given that a lot of people just don't get it, a lot of perpetrators don't
Yeah.
get it, do you have thoughts about what a broader population-based
Yeah.
policy response might look like?
Oh, so I had like other slides that I took out. But so in this room, in the places that I often work, we know child maltreatment is a problem. But you go outside of an academic area, and I'm with you 100%. People don't get it. They think it doesn't happen here, whatever. And so there is a need for a strategic, just like awareness, kind of like, hey, this is a thing that happens. Here's the public health problem of it, but just like kind of naming it and calling it out. So I did collaborate with some folks from the School of Communications at Penn State and did a, it was, pre-pandemic, pre-other things, but a Twitter analysis of a campaign, and looked at different messages and different visuals and what got people to click on a link. And when it comes to this message, numbers don't work. Pictures of kids do not work. But what did work were emotional, not necessarily emotional appeals, but more of a testimonial. Like, I, as a parent, went through this is what I learned. And pictures of kid-related things, but not a kid. So the greatest engagement I got on a post was of a teddy bear, not of a kid. And so I think there's a beautiful dissertation for someone to figure out a way to create a communication science evidence-based strategy about this public health problem to increase awareness. You want to do it?
Okay, we've got time for one more.
Thank you for this talk. Continue to sing your praises. This was so informative and
thanks.
learned so much. Technically, I have 2 questions if there's time for that. My first question was kind of harking back to the question asked about has this been implemented further south. Have you faced any pushback on implementation or kind of predict any pushback with we seeing laws coming up against censorship in schools, talking about sex ed, especially and more religious, like the Bible Belt down here? And then the second question I had, you kind of talked about it earlier. You mentioned child sexual abuse in online spaces and how to keep children safe online. And do you kind of have any ideas how to implement a program that kind of like looks at this online space where we're seeing like adult spaces and child spaces being interwoven online, and how to kind of protect children in this way and inform parents?
Okay, so first question was about coming south with these thinkings and implementation barriers. So I get a lot like, this doesn't happen here, or we already have a program that somebody made in their kitchen and that's enough. And I respectfully disagree and can show you data, and not from a decision maker perspective. When I showed them the number of cases in the past 2 years, they're like, oh, maybe this is a problem here. But, you know, more to be worked out in terms of those thinkings and coming into different geographic areas. It certainly happens in Pennsylvania. And then your other question about the online kind of situation, I made a decision with this curriculum that I'm not going to go into the particulars of online things because it changes so fast. Like, how could I possibly have a curriculum that is up to date? So instead, I'm relying on teaching parents skills about monitoring that they can apply to whatever cool thing comes out. And that's kind of been my strategy. But there is a need for more targeted and specific things. I think from my perspective, we just don't know a whole lot about that online space and what we need to do. We need to do something, but I invite someone else to work on that.
So from the audience here, sorry.
Yeah, I was like,
just wanted to thank Kate for coming and joining us. Thank you for being an incredible inspiration to our students about the impact of the degree that you obtained here. We're going to take full credit for everything that you do. But thank you so much, and we'll just send everybody on their merry way.
Thank you.